So a very warm welcome to today's ISNTD Connect, where we'll be taking a closer look at the hugely neglected and very poorly understood diseases that are Chromoblastomycosis, Sporotrichosis, and Mycetoma, which all come under the umbrella of Subcutaneous Mycoses. If it's the first time that you've joined us, welcome. And my name is Marianne Comperet. I'm speaking from the International Society for Neglected Tropical Diseases. And some of you who've been here before may recall from a previous ISNTD Connect towards the end of last year on the topic of mycetoma, that one of the main takeaways there was really this concern around correct diagnosis, which remains really a big problem across all regions of the globe. And so today, it's our pleasure to welcome a really important panel to delve a little bit deeper into these gaps on diagnosis, gaps on treatment, and also to mark the launch of the recent launch of a WHO survey trying to really tap into the global knowledge where we're at in terms of these gaps for subcutaneous mycoses. So we're taking a leap of faith here. We've got a wonderful panel, a very large panel, and tuning in live from every corner of the planet: Brazil, Madagascar, Sudan, Mexico, India, the US, and the UK. And we're going to hear a lot of really valuable expertise and insight. And we still remain in kind of a paradox where lack of data means there's lack of research, and lack of research leads to lack of data. So hopefully, to help us a little bit elucidate this paradox today, we'll be hearing from our wonderful panelists. And so without any further delay, I would like to introduce them and welcome. We'll be hearing first from Dr. Daniel Agraw. Daniel, you're from the Department of Control of NTDs at the World Health Organization. We'll also then be focusing a little bit more on specifically Chromoblastomycosis and Sporotrichosis, and we'll be hearing from Professor David Dagne from the Global Action for Fungal Infections, or GAFFI, and also a WHO advisor on these diseases. Welcome, Professor Dagne.
Hello, nice to see you.
We'll also hear from Professor Flavio de Queiroz from the Federal University of Paraná in Brazil. Welcome, Professor.
Hello, everybody.
As well as Professor Rapelanoro Rabenja, President of the Malgascar Society of Dermatology, and tuning in from Madagascar. We will then move on to the second part of this webinar, which will focus more specifically on mycetoma. We are hoping to be joined by Professor Ahmed Hassan Fahal from the Mycetoma Research Center and WHO Collaborating Center in Sudan. Professor Fahal is, I believe, not online yet, but we're working on that, and we have all faith that this will happen just fine. We'll also hear from Dr. Guadalupe Estrada-Chavez, dermatologist and working in community dermatology in Mexico.
Hello, everybody. Good day.
Lovely to have you here. We're also welcoming Professor Archana Singal, Head of Department of Dermatology at the University College of Medical Sciences and the GTB Hospital in New Delhi, India. Welcome, Professor Singal.
Thank you very much. Hello, everyone.
And to hear a bit more about the opportunities offered from drug repurposing, we'll hear from Dr. Marco Schito with CureID's Drug Repurposing Collaboratory. Welcome, Dr. Schito.
Hello, everyone. Thank you.
There we are. So a really impressive and important panel today. And without any further delay, I will soon be handing over to Dr. Dagne from WHO. Just one last thing on a practical level. We've got 90 minutes, a very packed agenda, and we really want this to be the start of a very collaborative process. So please, by all means, to our attendees, jump in on the chat, introduce yourself, say who you are, where you're tuning in from, your organization, your country. That's always really important and very valuable. And any questions that may arise, please do ask them, and we'll aim to answer those, and as many of those as possible, live during the event in writing on the chat. So without any further delay, I will hand over to Dr. Dagne, and thank you and welcome to everyone for joining us today.
Thank you, Marianne. Good morning, good afternoon, and good evening, colleagues from wherever you are connected. Please allow me to start by making a note about the recent passing away of our director. It's with deep sadness and heavy heart that we learned the devastating news of Dr. Mwele Malaselas, director of WHO's Department of Control of Neglected Tropical Diseases, passing away on 10th of February. Dr. Malachela was a passionate and inspiring advocate for eliminating neglected tropical diseases. She was also one of the most respected scientists and visionary leader who elevated NTDs to the forefront of the global health agenda. She magnificently guided the development of the blueprint Ending the Neglect to Attain the Sustainable Development Goals, a roadmap for neglected tropical diseases, from 2021 to 2030, which was launched in January 2021. Dr. Malachela will be remembered as an inspirational figure, a dedicated leader and listener, in addition to being a recipient of many distinctions and awards. She was repeatedly included in the top 100 list of the most influential women in Africa. Our deepest sympathies and condolences are with Dr. Malachela's family and close relatives, as the colleagues and friends in the global health community and around the world continue to mourn her loss. At this juncture, I would like to ask for a moment of silence to honor and pay our respect to this great leader. Thank you. Thank you. May her soul rest in eternal peace. As you all know, drugs, vaccines, diagnostics, and vector control products are important tools for the prevention and control of NTDs. Compared to many other diseases, a very small number of new diagnostics, therapeutics, or prevention tools for NTDs demonstrates a persistent gap in innovation, research, and development. A significant proportion of currently used drugs, either for mass or individual case treatments of NTDs or other infectious diseases, are repurposed or repositioned drugs. To cite few examples, we use ivermectin for scabies, liposomal amphotericin B and miltefosine combination for visceral leishmaniasis in the treatment in HIV co-infected patients, azithromycin for use, and so on. There are several examples of this. In the absence of new compounds, repurposing or repositioning of drugs has several advantages, including cutting drug development time and cost, non-safety profiles, and potential use for multiple diseases. In May 2016, the 69th World Health Assembly adopted a resolution, WHA 69.1, requesting WHO to include mycetoma in the list of neglected tropical diseases and to support member states in which mycetoma is endemic to strengthen their capacity to improve early detection and access to treatment, assess the burden of disease, and when necessary, establish a disease control measures. In this resolution, the Secretariat was also mandated to define a systematic, technically driven process for evaluation and potential inclusion of additional diseases among the neglected tropical diseases through its strategic and technical advisory group. In March 2017, the WHO Strategic and Technical Advisory Group recommended the inclusion of Chromoblastomycosis into the NTD portfolio with mycetoma and other deep mycoses. This was a significant step. recognizing the need for development of appropriate diagnostics and treatment tools, and the recommendation of the WHO 69.12. WHO is collaborating with various groups, partners, and institutions to help to produce the evidence base to support endemic countries in their effort to develop and implement control programs and achieve the NTD Roadmap 2030 targets. One of these collaboration is with the US FDA on the Cure ID program, which is an online repository for data from clinical case reports and clinical trials where existing medicines have been used in new ways to treat infectious diseases that lack approved treatments. The Cure ID program also includes a treatment discussion forum, mobile phone application, newsfeed of the latest infectious disease news, and database. One of the most important of the Cure program is to serve as a global resource for clinicians needing information to make informed decisions about difficult to treat infectious diseases in resource-limited settings. We believe that analysis of this clinical case data could lead to an enhanced understanding of safety and effectiveness of existing medical products, as well as stimulates medicine development and regulatory consideration of therapies for difficult to treat infections. There is no global surveillance system, database, or control programs for Mycetoma, Chromoblastomycosis, Sporotrichosis, or other deep mycosis, leading to gaps on knowledge on the magnitude and distribution of these diseases, in addition to the lack of synthesized information on the clinical practices in different endemic countries and regions. The main objective of the WHO online survey is to gather and analyze information on diagnostic capacities and treatment practices at all levels of the healthcare delivery in the different settings in the endemic countries. The survey will be used by WHO to inform the landscape analysis to identify priority disease areas for piloting in the Cure ID platform to help clinicians their experiences in managing these difficult to treat infectious diseases. We know that individual clinical experience, anecdotal evidences are not sufficient to establish the safety or efficacy of a new use of an existing product. However, pooled data set from different clinical practices, trials, or observational studies or diagnosed treated patients using reposition medicines are becoming a valuable source to inform global diagnostic and treatment policy about contemporary practices. Sharing the clinical experience in the use of approved drugs used off-label and capturing this in a systematic way is believed to contribute to a networking of actors, including major treatment centers, academics, researchers, health practitioners, and others to communicate treatment outcomes and other relevant information. We strongly request either your direct participation if you are managing these cases, or further dissemination of the survey links to relevant institutions and experts in your respective countries to help us in building up the epidemiological, clinical information, and advocacy of these difficult to treat neglected fungal diseases. Thank you.
Thank you very much, Dr. Dagne. This is a really important initiative. Thank you also for your very moving and touching tribute to Dr. Malicella, which everyone will dearly miss. I think something we've heard a lot in the last few days is that everyone's very committed to completing what she started and her vision, and this survey and the progress that's been made since the inclusion of Mycetoma on the NTD list is definitely in that way. So without any further delay, I'm going to hand over to Professor David Denning so that we can take a much closer look specifically at Chromoblastomycosis and trichosporosis. And also we'll be posting the link to the survey very shortly in the chat. So please do go ahead and have a look at the question posed and any expertise that can be added to this. The survey's in many languages as well. So please do go ahead to all our attendees to have a look at that. Thank you. And over to you, Professor Denning.
Hello, everybody. Thank you very much for joining. What we're going to focus on today is sporotrichosis, in the first half, sporotrichosis and chromoblastomycosis. And I'm speaking with my GAFFI hat on. we set GAFFI up in 2013 to really try and advocate for better diagnosis and treatment, and therefore better outcomes for patients with fungal diseases. And one of our areas of specific interest is in the NTDs. I just want to overview the size of the problem for you, which may not be obvious to you, but there's a lot of people who die unnecessarily of fungal disease. On any one day around the world, there are probably about 13 million people at risk. So these include people with leukemia, lung cancer, late-stage HIV infection, people in intensive care, premature babies, patients with severe COPD and asthma, and others. And there are probably about 2 million fungal-related deaths every year, which, if this was the primary cause of death, would make it the 5th largest cause of death. But as you know, with most of these patients, there is an underlying cause, whether it is COPD or cancer or prior TB or HIV or whatever. And in the HIV setting, slightly under half of HIV deaths are due to fungal disease, rather more than TB actually. And but there are many other groups. So if we were able to wave a magic wand today and provide everybody in the world with our current diagnostic tools and our current therapies, recognizing that none of these are perfect, we think that we would probably save about 1.3 million lives. So that seems to us to be something really worth trying to work on. Now, the next, I want to now just go straight to Chromoblastomycosis. So GAFFI made with my colleague who's on the call, Flavio Queiroz, an application to WHO to have this as an accepted NTD about 3 or 4 years ago. And it was accepted along with the phraseology of with other deep mycoses, which, just for clarity, means things that are fit within the NTD portfolio of affecting populations, vulnerable populations in low-income countries, for which there's a specific additional research needs to go forward with. Anyway, for Chromoblastomycosis, you can see that a recent paper hosted from Brazil with Dr. Daniel Wegner Santos portrayed all the cases that have been described in the world literature and mapped them. And you can see a lot of patchiness in this, in that there are clearly quite a lot of cases in, for example, Madagascar and Botswana and Gabon and Venezuela, and many fewer in other countries. And there are a lot of countries with no descriptions of this disease at all, which in Africa almost certainly means that this diagnosis is being missed, or it's not possible to make it because of identification of the organisms, or possibly there's no interest in writing these cases up. Sporotrichosis is a global disease in many ways. The frequency of infection is higher in certain places. For example, Peru seems to have a particularly high rate of infection for reasons that are not entirely obvious. Quite a lot of cases in Brazil and Mexico, and quite a number in China, and fewer described in Africa, although we know that it does occur in Africa. And there are different species involved, and we will hear more about these. And one of these is directly related to cat-transmitted disease. So this is also a zoonosis. So a group of people particularly interested in these fungal NTDs undertook a questionnaire survey, which was published about 2.5 years ago. Rod Hay from London led on this. And this compares the preferences for different approaches to diagnosis. And I want you to notice on the right-hand side that the majority of experts in this area particularly favored a punch or incision biopsy or a complete excision biopsy. You could get useful material from skin scrapings from if the skin was broken or if there are sinuses, particularly of Mycetoma grain. But an impression smear and a skin from a swab was not as effective from these things. So one of the key things here is that we need access to being able to do a biopsy in many of these patients. And that we've learned from a recent survey we've done in Africa is not universal. Not everywhere has the capability of taking a biopsy or of processing it. So if you have and work in a well-provided laboratory, then you'll see on the right-hand side, particularly, that histopathology is the favored means of establishing the diagnosis, but also culture is important and direct microscopy is important. Now, direct microscopy and histopathology is less sensitive for sporotrichosis than it is for chromoblastomycosis, and that's a particular problem. And some work that Alexandra Boniface has done and popularized, if you like, with a nice paper, shows that actually there's a skin test, a bit like a MON2 or TB test, which can be done, which if positive is very, very supportive of the diagnosis of sporotrichosis. There's also a blood test for sporotrichosis. You can measure sporotrichosis antibodies, but not many people do this. It is commercially available from IMI, and that might be a strategy for those of you who don't have the ability to do, for example, biopsies or direct microscopy. And then for those clinics which have much lower sophistication in terms of their ability to make a diagnosis, direct microscopy is very important in this. And some of these clinics have histopathology or can at least process the sample, and then if they can't interpret it, can send it to another agent for that. And we have set up, and I'll put it in the chat, an online free learning portal for microscopy and also for histopathology, which includes these pathogens, and that might be of value for those of you interested in training and learning more about them. Of course, once you've made the diagnosis, you then have to treat, and itraconazole is certainly the drug of choice for chromoblastomycosis and sporotrichosis. The organisms causing sporotrichosis are very susceptible to itraconazole. So in fact, 200 milligrams a day is usually enough, and usually 3 months is enough, although we'll hear more about the detail of that. But for chromoblastomycosis, there's a much better response with 400 milligrams a day than there is with 200 milligrams a day. But you can also see that there are some countries without itraconazole, and I just learned today that Morocco doesn't have itraconazole either. And so, although the purpose of today's seminar is very much about repurposing, we do need to get these drugs available in every country. And finally, before handing over to my colleagues, we've just launched some policy briefs on the GAFFI website. These are for different topic areas, but for those of you interested in laboratory facilities, there's quite a lot there, particularly how country health systems can adapt to combat the lack of diagnosis in many centers, and a specific policy brief about neglected tropical diseases. With that, I'm going to stop and introduce my friend and colleague, Dr. Flavio Queiroz, who works in Brazil, and he's going to address the issue of sporotrichosis.
Hello, good morning, everybody. It's morning in Brazil. It's morning in Brazil, and I want to thank for the organizer to invite me to this so important web seminar. My talk today is on sporotrichosis. I have only 10 minutes to convince you that sporotrichosis, it's the most important, prevalent, globally distributed implantation mycosis. I prefer this term implantation than subcutaneous, because as you know, mycetoma and sporotrichosis, they affect other organic sites beyond the subcutaneous tissue. There are several species of the genus Sporotrix causing this disease. Sporotrix is globally distributed, and some are transmitted by plants. They are sapronotic transmitted, and other are zoonotic transmitted, for example, as Sporotrix brasiliensis. And sporotrichosis has a feature. It's a special disease because it can cause clustered cases of outbreaks, and it can be an occupational disease also. If we look in the world, what is the estimative global burden of sporotrichosis? We expect that more than 40,000 new cases occurs every year, most of them in Latin America, especially in Brazil. Now, I would like to remind you that in the 90s, in the state of Rio de Janeiro, south of Brazil, the scientists start to record a new species causing cat-transmitted sporotrichosis, and the number of cases of human case, feline case, and canine case is increasing, still increasing. Actually, we have thousands of notified and non-notified in human case, feline case, and hundreds of sporotrichosis in dogs. This outbreak expanded in Brazil and outside Brazil in some North South America bordering countries. In 2019, the WHO launched an alert about this species. The species is still in expansion in South America, and we don't know in Latin America. Now, I would like to show you some data of my hospital. My hospital in south of Brazil, Hospital de Clínicas, Federal University of Paraná. And you can see in this table how the number of cases of sporotrichosis, especially cat-transmitted sporotrichosis, increased from 2011 to last year. The incident rates raised from 0.27 to 30. It's incredible how it's expanded. And I would like to show you something, a detail. If you see the jump of cat-transmitted sporotrichosis in 10 years, during the COVID lockdown period in Curitiba, a lot of family adopted or incorporated pets, cats and dogs, to lessen the anxiety among the confined children. And this brought a raise in the number of cases, especially in the last 2 years. This you can see in this graphic. Well, I'd like to tell you that cats can transmit Sporotrichs brasiliensis not only by scratch or bites, but especially by the exudate splashing from these ulcerated lesions, and maybe from the respiratory secretion during cough or sneezing. We are trying to prove this, but I would like to show you how great is the fungal burden and this secretion from this poor animal, and it's easy, can reach your integrate non-disrupted skin barrier and also the eye mucosa, causing granulomatous conjunctivitis. And I'd like to remind you, this Sporotrichs brasiliensis is unique among the dermophic fungi that can be transmitted directly from the yeast form. This is unique among the dermophic pathogenic fungi. There was one of our PhD students, Dr. Darus, was trying to prove that the sneezing, the respiratory secretion from during sneezing of the cats can transmit sporotrichosis also. It's easy. You can easily isolate in this kind of organic material from the cats. Well, let's come back to Curitiba. Among our 176 patients, most has present the lymphocutaneous form, some has the fixed cutaneous, but we have many cases with eye involvement and immunoallergic forms. This is especially related to cat-transmitted sporotrichosis. And of course, the immunocompromised patients can present cutaneous disseminated form. This is it's a very severe disease. It causes a lot of morbidity and sometimes mortality among these patients. AIDS, chronic alcoholism, diabetes, and medullary aplasia. Cat-transmitted sporotrichosis is a risk factor from some populations, especially for veterinarians, students, residents, technicians, pet house workers, etc., etc. This is a veterinary resident from Curitiba who presented sporotrichosis, a lymphadenopathy. So, sporotrichosis is also an occupational disease. But to finish this, I would like to show you, my friends, that Brazil is exporting mycoses. Why? Because this animal, the sick cats, they don't need passport or air ticket to cross the border. There are some proved cases in Argentina and Paraguay and probable cases in Bolivia. This is a recent paper from Argentina showing more than 20 cases in the Buenos Aires region and also in Patagonia, in El Calafate. So Sporotrichosis brasiliensis has crossed the border, reaching Argentina, Paraguay, Bolivia, and perhaps other countries. How can we combat this epizootic outbreak of Sporotrichosis brasiliensis? There is no chemoprophylaxis, there are no vaccines. Fill-in therapy, the therapy of sick cats is a big issue, and then control of these animals is a giant issue. But we can put efforts on early diagnosis. How? As Professor Dagne showed, the culture is the gold standard diagnostic tool, but it's time consuming. This is a slow growing organism and samples may be contaminated. Direct microscopy and histopathology both has lower sensibility. Serologic tests like latex, ELISA, etc., they usually are not commercially available. And sporotrichine is not useful in most of the country because it's only an in-house test, cannot use in the public health system. Now in Brazil, we are adopting the criteria for diagnosis of cat-transmitted sporotrichosis in a probable level. What is a probable sporotrichosis? We take into account the history of trauma and contact of the patient with sick cats. The patient must present suggestive lesions, skin, lymphocutaneous, eye lesion, and this is a very important. The veterinarian diagnosis, because it's easy to make the diagnosis in cats. We take into account all information brought from the patient related to the story in his pet, in his animal. Okay, this is very important. Most of the cases are diagnosed under this criteria. How this is important? Because if we take into account the probable evidence level, we can reduce morbidity in the clinical manifestation, and we also can reduce the duration of therapy with systemic antifungal. I will show you what is the late diagnosis of sporotrichosis in patients from my hospital. Involvement of the eye, AIDS patient, lymphocutaneous, and this is, we don't want this. We want to treat our patients very early, based on probable diagnosis. Itraconazole is the drug of choice. We have itraconazole given free for the patients by our Ministry of Health. And secondarily, we have terbinafine and secondary option include terbinafine and potassium iodine solution. These are patients treated with itraconazole. Finally, I want to remind you that we must have one health approach to understand sporotrichosis. We need many kinds of professionals, including veterinarians, environmental scientists, microbiologists, etc. This is the way to combat this zoonosis in Brazil and in South America. Thank you for your attention.
Great, thank you very much for that. So if you want to stop sharing, Flavio, that would be very helpful.
Sure.
Now it's my pleasure to introduce Professor Rapelanaro Rabenja from Madagascar, who's also president of the Madagascar Society for Dermatology.
First of all, I would like to thank here the organization committee to give me the opportunity to talk about Malagasy experience in management of Chromoblastomycosis, Sporotrichosis, and a little bit Mycetoma. Madagascar is the fourth biggest country in the island in the world, and his area is bigger than France and Benelux. There are only 15 dermatologists to take care of 26 million populations. The climate is very rich. In the east, north, and northwest, we have humid and tropical climate, and we found Fonseca pedrosi. In the southern, the climate is semi-arid, and we have Claudiophora coronui. You see in this map the difference of vegetation in the north and the south. Chromoblastomycosis and Sporotrichosis, as you hear before, is a subcutaneous tissue fungal infections, and it's result from the introduction of certain causative agents, spiny plant via a skin injury. We see here many plants: Aluada humbertii, Mimosa lapitinosa, Agave. This plant is we study this plant if they have a link with the Chromoblastomycosis in Madagascar. And we see here women working barefoot in the field. If you talk about the history of Chromoblastomycosis in Madagascar, the first case were probably found in 1940 by Rapelanoro and Guillet, and the first identification case of the species is done by Pasteur Institute in Madagascar in 1956. They show that 62% of the isolated strains belong to the Fonseca pedrosi species. And in 1996, another study saw that Madagascar is the largest focus of this disease in the world, and it's counted in this time more than 1,300 cases. And many cases were located on feet and legs. This is a map from Flavio Queiroz who shows this Madagascar important cases with more than 2,500, and especially Fonseca pedrosi and Claudiophora carioni. If you compare to Brazil, China, and Mexico, Madagascar is far away. What about Sporotrichosis? You move to cat zoonose Sporotrichosis to Sporotrichosis from soil and plants. And at the beginning, the first case described in Madagascar of Sporotrichosis is known around 1998. And we have a few cases in these publications if you compare to this country. The aim of this study is to demonstrate that the skin diseases are still endemic in Madagascar. You see here the team. Sample biopsy and squamous cell prelevement were done by Department of Dermatology and histopathology by the Laboratory of Histopathology in the capital. The mycological culture and molecular biology by Center d'Infectiology Charles in Madagascar, and molecular biology and Malditov for species of Sporotrichosis by University of Grenoble, Laboratory Parasitology, Mycology. I show you the map of our field mission in endemic area during 8 years. Here we are in hospital in Tuléar in the south, and here in hospital in Antananarivo in the capital, and the hospital center in Andap in the north. We recruit during these 8 years 3,023 cases, and the same result from the study 20 years ago, more male predominant of the cases, and half of the patients are farmer, and you have this, the distribution of the country. One of the very important intervention of this study is the dermatological diagnosis. You saw here 3 different cases at the beginning. Here we have tumorous KB keratosic here, and here we have a single nodular lesion with raised border, and here we have a papillosquamous lesion like a cauliflower. And we try to identify the cases in the map of the country. Here we have a tumoral crust uniform in the east, and in the middle we have a placar uniform in the north, and here we have varicosis form like a cauliflower. And for sporotrichosis, we have a crust lesion, tumoral, sometimes unique form, but there is also the nodular varicosis form. And here we have a lymphocytic form along the leg. And there we find there all over the country. We start to diagnose some case of Mycetoma, but it's a little few in this study. We have only 9 cases of Mycetoma, and we just use clinical diagnostic and laboratory. This map distribution of Chromoblastomycosis and Sporotrichosis so that we have the same place if you compare to the study 20 years ago. But one of our specificities to include a botanist in our staff to study the plant environmental, to make a links between the plant found around the country. This is a microscopy to show just the macroscopic appearance of colony of Cladophyalophora colony, furry and dark gray in macroscopic appearance, and fluffy and black in Fonseca pedrosi. And this is a fumagoid cell specific, and this picture comes from our laboratory. Skin sample, as discussed before, come from Department of Dermatology and they use skin biopsy for DNA extraction for PCR and sequencing, and for Malditov and phylogenetic study. The results show that in the 323 suspect cases, we have 92 confirmed cases in sporotrichosis and 60 cases in chromoblastomycosis, 9 only in Mycetoma. But one specific finding is the 24 cases of Fonseca nubica. 20 years ago, it's called pedrosi, and this is new in our study. And for sporotrichosis, all of the cases Sporotrix schenki. And you see here, for Mycetoma, you are only possible case because they have no specific identification of this disease. What can you do? What can you say about this difficult management of this disease? Many cases referred at the Department of Dermatology late because there is a misdiagnosis or unknown, and this disease are unknown by Madagascar physician, and many cases are seen late, like this Chromoblastomycosis and Sporotrichosis. The national NTD program lacks the capacity for sustained surveillance of this disease. There are few clinical specialists to diagnose at the beginning the disease, and a few laboratories who can perform the diagnostic of this disease. The Chromoblastomycosis and Sporotrichosis need a long-term and expensive treatment and need a follow-up. You have many cases lost of follow-up. For the treatment, we use especially itraconazole, as described before, 200 milligram orally one time, and the result is non-homogeneous. We have some cases with marked improvement after 6 months, and there are no improvement after 1 year. And in this map, you have for the Sporotrichosis, 11 cured after a middle of 6 months treatment, and for CBM confirmed, only 2. That means that it is very difficult to treat CBM, and they need even you go up to 24 years, you don't have a result. What concludes? Mycetoma Sporotrichosis still endemic in Madagascar. Sporotrichosis have a high significant case in the country. CBM have a high level prevalence if you compare to the description 20 years ago. But this disease need a long follow-up and long-term treatment that many people cannot afford. You need a collaboration between partners like ISNTD and biological diagnostic of Mycetoma. You need this too, and you need to develop environmental investigation in source of contamination in order to clarify the geographical distribution of the agents. I take this, I show you the reference of publication from Madagascar and published in high impact factor paper. I take this opportunity to show you, to invite all of you to participate at our 70th International Congress of Dermatology, World Skin Health Day, that the topic is neglected tropical dermatosis, and you want to include atopic dermatitis and the use of teledermatology to resolve the problem, because our country has a lack of specialists. Thank you for your attention, and welcome to Madagascar.
Great. Thank you very much indeed for that lovely talk. Beautifully illustrated and very interesting. I do think maybe the dose of itraconazole needs to be higher, but of course I understand the financial limitations that you face in your country, for Chromo anyway. Do you want to stop sharing your screen now? And we would next due to have Prof. Ahmed Fahel, who I think almost everybody on this call will know or know of. But unfortunately, he's not been able to join us for reasons that are not entirely clear to me. So I think in the interest of time, we should probably move to hear from Dr. Guadalupe Estrada-Chavez from Mexico. And she's going to talk to us now about Mycetoma. So we're going to shift from Chromo and Sporo to Mycetoma. Is that all right?
And a huge thank you as well to yourself, Professor Dagne, Professor Rabenja, Professor Telles. I've always viewed our cats with a bit of suspicion, but now definitely more so. And Thank you for giving us this very broad overview and much deeper understanding of the gaps and the challenges remaining. Just to remind everyone, we did post a link to the survey. So if any of what we've heard today has triggered some sort of contribution or input, or even if you've just given this umbrella of skin NTDs, have thought of any colleagues that you would be able to share the survey to, please do go ahead. But now, as Professor Dagne said, we're just going to move on to the mycetoma part of the webinar. And please keep asking your questions in the chat. Thank you. Our panelists are there on hand to answer those as and when they come along. Thank you very much.
Thank you, Marianne. Well, today, unfortunately, as you heard, we were not able to have Professor Fahal with us, but we will start having the information about mycetoma. But first, I would like to thank all the organizers for the invitation to participate today. I will be talking on behalf of our small dermatologist group in Mexico. We are a small family group, and we will be sharing our experience regarding actinomycetoma. As you all know, well, mycetoma is a worldwide disease that is mostly in intertropical areas, also known as the mycetoma belt. And these endemic areas like in India, Sudan, Brazil, Venezuela, and Mexico. And we have a high index of actinomycetoma in Latin America. Mycetoma is more frequent in Africa, Asia, and India. And as you heard, mycetoma has been recognized as an NTD since 2016. Mycetoma is an inflammatory chronic syndrome. It affects skin, hypodermis, bones, and sometimes even bowels. It is very well characterized by volume increase, fistula, symptomatic, purulent, exudate, and the parasitic form is also known as grains, and with a very clinical features that will help us to identify it clinically. The mycetoma is a neglected disease. It has been neglected in endemic areas, not only by patients, but also from the communities, from medical authorities, and from health authorities in general, which is something to be very regretful. Something that is very frequent and that it has been the common denominator is poverty. There is a late presentation of the disease, and that mostly is because it causes none or very mild symptoms, which will cause serious consequences for these patients. And most of them will be working in the fields and will neglect their own disease. Mycetomas in Mexico are mostly actinomycetomas, in 98% of them, caused mostly by Nocardia brasiliensis or Nocardia species. And mycetomas is only 2%. But in our state, Guerrero, which is in the southwest of the country, we have up to 9%, depending on the year, from mycetomas. You all know that farmers are the most affected work group, and it's mostly because of mild or minor trauma with acacia tree thorns. We know them in Mexico as huizache. But we have identified that there are sometimes unusual vectors like animal bites or even insect bites also can cause as a vector, as an entrance, or have been referred from the patient. Something that we will address a little bit ahead is about the iatrogenic, that it can be associated to mycetomas. We have seen some forms that are not frequent, like a cryptid or a fistulized mycetomas. And the area that is most affected is lower limbs. But we have identified some other cases affecting back, neck, abdominal, perianal, and cervicodorsal, which is the latter is mostly of relevance because of its high morbidity. This is a publication that it was done by Dr. Chavez, Dr. Estrada, and Dr. Bonifaz about perianal actinomycetoma, which even though it's not a frequent topography, it is related to the cleaning habits in the field. And also, as I mentioned, the importance of identifying and diagnosing correctly and treating in a good way the cervicodorsal mycetomas, because it can cause severe morbidity, even arriving to quadriplegia, which is a very interesting point and to focus on treatment. Mycetoma is in our state in Guerrero. As you can see in the map, this is Guerrero, and this is only the state where we live. Acapulco is in the middle, and it's called the small coast, the big coast. And of course, we are in the middle of the state on the sea. But something that it calls our attention is that especially those areas is where most cases of mycetoma we have found. And it's mostly because it has very specific environmental characteristics, and there is also with a high endemicity of mycetoma, which is a very interesting point for us. The community dermatology program in Mexico, we have reported in the last year our 115 mycetoma cases, from which over 80% were caused by actinomycetoma, but we had over 19% of mycetoma, which is very interesting in our state because, as I mentioned before, the statistics of the country, it's more or less 2%. Mycetoma is very important to diagnose it early and appropriately to receive the treatment, because as you know, it can cause very severe and deep involvement. It can affect bone structures, and it can become a very disabling disease. That's why effective management is still a need, and I think that's why it's so important, the relevance of this kind of sessions, of these webinars, because it opens the door for having more knowledge and collaboration between different organizations. Something that we are focusing is creating awareness about the NTDs at the communities. That is why we give a basic dermatology training course for medical pasantes, which are the last year medical students working at the social service at the communities. And also in endemic areas and endemic communities, we give another course for the health personnel so they can learn how to identify the different presentations or the clinical features of mycetoma. So we have had a good success with the education of these physicians, and also we invite the students whenever they are allowed because of different reasons now with the pandemic. And it's not only the health personnel, we also put these posters in the different community centers or the health centers at the communities, in which we make a little bit more of awareness on the clinical features of mycetoma, because at the end, it's not only the physicians that want to learn. Patients also want to know what they have, and they want to get involved in their treatment, because whenever they understand that part, they will be more interested. And we have been very fortunate to have over the years, over 30 years of working in community dermatology, very interesting, very nice, and very kind support from different associations, and like the IFD, the ILDS, and the AAD, either for working support, economical support, or treatment. And we always appreciate the help and the support from Professor Hay and from Dr. Claire Fuller also, because they have joined us for this jornada that we go to the different communities. We want our patients to receive a proper diagnosis, a proper treatment to prevent patients to evolve to this kind of clinical aspect. Let's remember that education on patients is also very important. Prevention, the mouth-to-mouth information, because this promotes medical care, and then patients will be less frightened to treatments and gives them the sense of care. That's why education in these patients is always an investment, and it can be starting from very early ages, as children are often working at the field. So that is something very important, that we get them involved in the disease and the treatment, and of course, try to find the proper treatment and the proper diagnosis whenever it's possible. And so we can then avoid the patient to evolve to these severities and to becoming such notorious lesions. And one of the problems is that some patients sometimes are very frightened of receiving treatment because they are ashamed either from the area that can be affected. So that's why it's so important to let them know that it's okay and that they can have a proper treatment in an early stage, that they can get cured and try to limit the progression of the disease. And we also have been collaborating with other groups. We have been, we reported epidemiology of mycetoma in Mexico as a group, and with other groups of different areas of the hospital of the country, and also try to let know our experience related in community dermatology, because I think as much as we can spread the voice, it will cause a better impact for the benefit of our patients. What our challenges is to try to give solutions for the NTDs. We want to reduce the stress and stigma of these patients. We want to improve the quality of life. And patients, as you can see in this image, this is from our small center of community dermatology in Tixla in Guerrero, which is in the center of the high mountain. And we want to improve their quality of life. We want to avoid these patients to get iatrogenic treatments, which are unfortunately very common. And we want to improve their skin health through education, awareness, and advocacy. Our treatment challenges is that most of the patients delay their diagnosis and poverty because there is a lack of resources, of knowledge, and available treatments. And even now, worse with the pandemic, has limited a lot some of the treatments or the distribution of certain medications. Diagnostic tools are still not available on endemic areas, that's why it's so important to have them, all this consensus. And the current treatment of mycetoma is still suboptimal. That's why also we have low cure rates. There is a frequent recurrence after leading to amputation, especially in a mycetoma. And as it is a painless, low progressive disease, it can be very troubling and very neglected in time. Patients will always prefer to spend in basic needs before having some medical treatment for something that is not painful or doesn't cause a limitation in their activities in a daily basis. There is an unfortunate that we have not enough, there's not medical records and statistical information. It is deficient. That's why we don't have enough adequate data to mycetoma incidence and prevalence. Most of our patients, and this patient especially, is a patient that had an actinomycetoma very severely, and they disrupt treatment because we assured him the treatment, but in that way he was very fearful, and the family told him that he would get sick if he got that medication for such a long time. Let's remember that patients with mycetoma will need a not long-term treatment, and therefore this patient sometimes will be afraid of it, and it's already difficult to get them the treatment. So it's a pity that sometimes they are not very aware on the consequences of suspending certain treatments. We want to reduce the burden of skin diseases because the incomes of these patients will be very limited, and the health resources are also limited, and we have to have available trained physicians properly. And patients are frequently discouraged from seeking medical attention. About treatments, there have been very interesting articles like this one of Professor Bonifaz about specifically related to actinomadura madure. And there are some other treatments of actinomycetoma. In Mexico, unfortunately, Dapsone, we don't have it available anymore. So we have to get in hand of whatever is available at the moment in the different regions of the country. And some of them, even if they would be available, they only have to be or can be applied in institutions, and they are very expensive. So that will not be affordable for the patients in most of the cases. So then why mycetoma is iatrogenized? Because it's misdiagnosed, frequently confused as osteomyelitis, and actinomycetomas are treated with antifungal sometimes or topical antibiotics sometimes by GPs. So it's really frustrating sometimes. And like this patient that was diagnosed wrongly, and he received surgery every 2 months. But it's even more troubling because these patients are farmers who lack a lot of resources. I would like to conclude to mentioning that distant communities lack the specialized attention. Isolation, poverty, ignorance, those are the main contributors for serious conditions. That's why we have to address that point. Medical attention and medicines are difficult still to get in those endemic areas. And I think it's something that we share with other parts of the world. And community dermatology program, that is why we are dedicated to try to solve this problem from the dermatological point of view. We want our patients to have a healthy, colorful life, regardless of the limitations, of the daily limitations. Thank you very much for your attention. And I will hand now, I will stop sharing my screen. Just give me 1 second. I will stop sharing the screen, and now we will have the presentation of Professor Archana Singal. She will talk. She is the head of the Department of Dermatology from the University College of Medical Sciences and GTB Hospital from New Delhi, India. And she will also share with us her very valuable experience in this session today. Thank you very much, Professor.
So thank you very much for having me on board in this important webinar. So I'll be talking about challenges related to mycetoma diagnosis and treatment in India. We all know that mycetoma is a chronic devastating subcutaneous disease associated with high morbidity. It affects social and economically underprivileged section of the society, especially in the rural area, and is endemic to the mycetoma belt in tropical and subtropical region. However, the actual endemic area extends much beyond this belt, as is evident from this global mapping by Professor Dagne, which shows that the mycetoma has been reported from practically every country across the globe. The disease burden, as you can see for India, may be highly reported, and this may not be the actual disease burden, because it is not a notifiable disease, as unlike tuberculosis or leprosy. So most of the cases go unreported, except the ones who are published get noticed. And India has almost equal representation of both actinomycetoma and eumycetoma, though there is a state in the northwest region which has more of eumycetoma cases, but we do have actinomycetoma and eumycetoma coming from all across the country. Coming to the diagnosis, the mainstay of diagnosis in our setup is clinical, and it has to be supported by lab diagnosis. We look for the age group and the site of the lesion, because mycetoma is more common in adults and it's less common in children. Foot is the commonest site involved, but any other site, as shown earlier, can be involved, and it presents characteristically clinical triad of painless subcutaneous mass, multiple sinuses, and discharge of grains, which can be of different color, size, and consistency. You can see this is an 8-year-old child who presented with discharging lesion of 2-year duration of actinomycetoma with underlying bony lesion. And there can be, these are the both actinomycetoma and eumycetoma cases on foot, on the leg, upper extremity, and also on the forehead. So any part which is exposed and trauma prone can be involved. The management of mycetoma, the actinomycetoma, is by combination of various antibiotics for a long time, predominantly penicillin, cotrimoxazole, dapsone, amikacin, streptomycin, rifampicin, etc. Though Welsh and modified Welsh regimens are conventional treatment, but in India we usually use this 2-step regimen consisting of an intensive phase of therapy with injection penicillin or amoxicillin, plus injection gentamicin or amikacin, plus oral cotrimoxazole for 4 to 6 weeks initially, and that is followed by maintenance therapy with oral amoxicillin and cotrimoxazole for at least 6 to 8 months, or maybe up to a year, depending upon the clinical resolution. For eumycetoma, the treatment is more challenging. At the therapeutic antifungal armamentarium is very narrow, and the relapses are frequent even after complete apparent clinical cure. And the drugs are just itraconazole and ketoconazole, because voriconazole has to be reserved for life-threatening fungal infections, though many people use it often. Sometimes eumycetoma is not amenable to antifungal alone, and therefore it requires surgical intervention such as debulking and amputation. So what are the challenges in India? Late presentation is the norm, and diagnosis is often delayed, leading to significant deformity and disability at the time of presentation. And the diagnostic delay of 2 to 15 years from the disease onset has been reported, and due to multiple factors which can be patient oriented, like there is insufficient patient awareness in the rural, social, and economically backward areas. And because of the painless nature of the disease, patients tend to carry the disease for a much longer time. There is scarcity of health facilities in rural areas. So every patient has to, go to the close by town or metropolitan cities, which has a great burden on the patients already who belongs to low socioeconomic status, because he has to visit, spend money on travel and on the diagnosis and management. And there is overall low health education for these patients. The physician factors are that the lack of qualified physicians in the endemic region or the rural areas. There is low awareness amongst physicians who are there for the disease recognition. So there is quite high probability that there is misdiagnosis of the disease and eventually mistreatment. And last but not the least, there are limitation of diagnostic tool in the rural areas where the disease is endemic. So this patient was in late 20s, female patient who had 3-year history of actinomycetoma. The disease appeared very benign, but on X-ray you can see there is marked destruction of the bony bones of the foot. So this because patient came later in the disease process. Now coming to the challenges with the diagnostic tools. The direct microscopic examination of the grain is very rapid technique, but it lacks specificity, and the grains are not always visible when the patient comes, and they may not be always able to get collected. Cytological examination of a smear is a rapid and simple tool, but it may not be diagnostic. Histopathology can give accurate results, and we often rely on histology for, especially when there are grains in the tissue reaction sections. The culture in sterile conditions and expert hand has high yield, and it is a gold standard for any infective disease, but it is frequently negative. I'll tell you why. Imaging provides clue to etiology and the extent of damage, but it do not give species identification. Molecular techniques, though, may provide an accurate identification of the causative agent, but they are not available in majority of the centers in India. So there is an urgent need for simple, accurate, reliable, cost-effective, and field-friendly diagnostic test for mycetoma. At the moment, the clinical criteria remains the most important clue, but they also have their own limitations because there are so many differential diagnoses. So an ideal diagnostic tool for mycetoma is still lacking, and the combination of technique is always required, especially in a resource-poor setting. Now, the cultures are frequently negative, and this is maybe because of there is inappropriate sampling. There is more of subcutaneous tissue, and then the grain is not available. There is often bacterial contamination, which inhibit the growth of both bacteria and fungi. Now, the most important issue in India is the previous treatment with multiple courses of oral antibiotics and antifungal. All antibiotics are OTC and can be taken up by the patient himself. It can be dispensed by the pharmacy, and it can also be advised, because it's not in the knowledge of most physicians that the treatment of mycetoma will require prolonged month-long therapy with antibiotic and antifungal. So they tend to switch doctors, and they tend to take multiple courses of antibiotic, promoting antibiotic resistance also. Another important cause for the failure of culture to grow is improper handling of the culture media, because ideally the biosafety cabinet is required, which may not be there in many institutions or tertiary care centers. SDA medium may not be sufficient to grow mycetoma. And lastly, the PCR even has to be the bacterial contamination has to be dealt with by treating the sample appropriately, which is not often done. So what we do, we just rely on the characteristic features and see which way the balance is tilting in absence of culture. So the histopathological feature, as I said, is the most reliable, and we often rely on the diagnosis of mycetoma, mycetoma and actinomycetoma based on the histology. There are red to pink fungal colonies in mycetoma, which stain positive on PAS. And on actinomycetoma, we get to see blue-colored gram-positive filamentous bacteria. Coming to the challenges with the management, as I said, the antibiotics and antifungal drugs are required for months, maybe for 9 months, 11 months, or a year. So the drugs are not free in majority of the government run hospitals. So either these drugs are not available or their supply is very intermittent if they are given free. So there is discontinuity of the treatment. Affordability is always an issue, especially for itraconazole, as it's a pretty expensive drug. And the quality of itraconazole is often questionable for many itraconazole brands which are available in India and which are available free of cost in government-run hospitals. Since the itraconazole or ketoconazole we often use has to be monitored for the potential hepatotoxicity, the monitoring also carries an additional economic burden on the patient. And in mycetoma, and all these lead to poor compliance. The surgical intervention is required for many cases of mycetoma, which is not often undertaken, even in the big hospitals due to lack of time from the surgeons, heavy workload, and there is expertise constraints. So we have very few limited number of surgeons who are ready to debulk the mycetoma lesions. I'll tell you just our experience with mycetoma in last actually 3.5 years, because for 1.5 years, my hospital was full COVID facility and we could follow up only 11 patients till date in the last 3.5 years. Rest were lost to follow up for COVID. And you can see that the culture was positive only for 2 cases, one for mycetoma and one for actinomycetoma. And one the cases relapsed, though we could treat them with medical and surgical modalities. This is the mycetoma histology, and this is the actinomycetoma histology where Splendor-Hoffley phenomenon is positive, and there is a dense mixed inflammatory cell infiltrate. There's some of my experiences. These are the pre and post-treatment pictures after the 8 months of treatment for actinomycetoma with injection amikacin, amoxicillin for 4 weeks, and cotrimoxazole orally with amoxicillin for another 7 months. Good response. Another patient who had been, where the lesion was surgically excised by a solo practitioner 2 to 3 times, but the subsequent histopathology after excision showed features of actinomycetoma, and we treated her with 10 months duration and with proper healing. Now, the mycetoma case required surgical debridement. This is a 62-year-old male with lesion on the foot, which was surgically debrided, and it healed by primary intention. And patient was given itraconazole with complete resolution. But after 6 months, patient's son came with the, again, discharge of black grains. So mycetoma is very challenging to treat, and the relapse is often seen. This is a slide from my colleague from South India who treats all his mycetoma cases with ketoconazole and has not encountered any case of hepatotoxicity, so good for him. So the way forward is there should be standardized treatment protocol for mycetoma and actinomycetoma, because at present, the treatment for both is currently based on expert opinion and the availability of the drug locally. The prevention outline has to be in place. IEC material and aggressive formal and informal health education of both community members as well as the physician in endemic areas. Early recognition and reporting of all the cases will help establish epidemiology, etiology, standard treatment protocols, reduction in complication, deformities, and improved treatment outcome. There should be more emphasis on active research, more facilities for species identification in endemic area, and there can be regional center for molecular diagnosis where the samples can be transported. There should be dedicated session on NTDs in major national and international and state conferences to make people, dermatologists, aware about the neglected tropical diseases and how awesome one can feel when you treat them, and they give so much good aesthetic results. And formation of special interest group, which we have done in our dermatology community. And there is a special interest group for neglected tropical disease who arrange symposia and webinars in different states, which are high endemic regions. So thank you very much for your patience.
A huge thank you, Professor Singal and Dr. Estrada-Chavez. Thank you for these really invaluable points, your experience from a country perspective, but also outlining the whole scope of issues from that delayed diagnosis, Professor Singal, you told us about, and then all importantly, to all those really vital approaches and initiatives to engage the affected communities themselves. So that was incredibly informative. Thank you so much. And we're just going to move to just the final presentation of this webinar. I'd like to hand over at this point to Dr. Marcus Schito. Dr. Schito, you're speaking representing the CureID Drug Repurposing Collaboratory, and you'll be outlining some of the opportunities offered there to tackle these difficult diseases. Over to you, Dr. Schito.
Thank you very, excuse me. Thank you very much, Marianne, and also thank you and the International Society for Neglected Tropical Diseases for pulling together this incredibly informative series of talks within this seminar. I'd like to just begin thanking really some of my collaborators, Barbara Milani, who's at the WHO and in contracts at the WHO, and has actually been the brains behind the survey that that has been circulated and is currently out there for completion, and also Heather Stone at the US FDA, who is really the brains behind the CureID platform. And I'll talk a little bit about those two sort of efforts and how they integrate potentially with each other. But before I do that, I do want to sort of give a little bit of a background on the Cure Drug Repurposing Collaboratory where I'm at. This was a collaboratory that was launched as a public-private partnership with both the US FDA and NCATS. And I'm wondering, Professor Rapenello, whether you can mute your line. You can hear a little bit from your background. Thank you very much. And as I was saying, we're a public-private partnership with the US FDA, and also in partnership with NCATS, which is the National Center for Advanced and Translational Sciences, one of the institutes at NIH, back in June of 2020, and really pull this group together to bring a number of stakeholders, not only clinicians, but other groups that have interest, including patients, together to address how drug repurposing can be further accelerated. And why are we doing this? Is because we really want to maximize the utility of the existing drugs that are available to treat diseases of high unmet need, and what more high unmet need that we can see based on many of these conversations as well as presentations that we heard today. So a little bit about CDRC. We're actually one of 25 active consortia programs within the Critical Path Institute. We're an independent, non-for-profit organization that was started back in 2005. We act really as a neutral convener and facilitator to provide actionable solutions through a number of different innovative data sharing collaborations. We have not only logistical capabilities and scientific infrastructure, but legal ways in which to accelerate, and more importantly, try to de-risk medical product development process. Our offices are in Tucson. I am located in Arizona in the United States of America, but we have recently, just a few weeks ago, actually stood up a new office in the EU in Amsterdam. And so we will be now more global and participating in many of the EU initiatives as well. A little bit about the platform that I had mentioned earlier. This was presented by Heather Stone, I think the last time that ISNTD presented at a conference on this. This is actually a web-based tool that was launched in 2019, and it's a platform to capture novel uses of existing drugs. It's essentially a crowdsourcing application with that can both capture as well as share real-world experiences in treating patients through a simple online case report form. This was, a culmination of efforts that was done over the past decade, and many of these locations that we want to be able to engage with, and the physicians and the the individuals that are doing the treatment are in middle and low income countries. And so we realize the fact that we have to have a platform that can cater to those capabilities, and that's what it's been designed to do. But the end result here is not only to contribute, but for individuals to come in and explore, find out how other physicians are treating the same disease in different parts of the world, their challenges, their issues, and to be able to discuss that in a collegial way. So the intent here is really to capture and gather more information in a way that can systematically be captured and then evaluated, and formulate really a hypothesis of how and both what can be addressed in clinical trials in the future. This can be freely, it's a free program, can be freely downloaded. The link is here at cure.ncats.io. It's also available on a smartphone or other mobile device in both Google Play and the App Store. The data that we're looking for is really concentrating on one major issue, and that is what off-label treatments are efficacious for the treatment of the disease. And in this case, we're looking for clinician-submitted case reports where we ask really 6 major questions. What disease did your patient have? How did you make the diagnosis? What made your patient's infection really quite difficult to treat? And for example, here is the list of answers that anyone can, as you're putting in your information, can click through. So these are radial buttons. There's always an other field to add in additional information. What drugs did you use to treat the infection? What was the patient's outcome? And again, this is not getting into the details, but did the patient get better? Did the patient get worse, or was it about the same? Those are the level of information that we're looking for. And then did the patient experience any adverse events due to the drug treatment? So for example, the hepatotoxicity that was discussed earlier, that brought up earlier. There are additional data elements that you can include in here, including things like comorbidities and demographic information as an example. But a new version, I'd like to also update this as that a new version with updated functionality, really based on a lot of the user feedback that we've been receiving, will be made available in the coming months. So be sure to look at this on a regular basis as we go back to this and bring out new versions and updates in the future. Oops. So a little bit about the collaboration. WHO has really been collaborating with US FDA for a number of years, and since the inception of the Cure Drug Repurposing Collaboratory in the last year and a half, the WHO has really led the landscape analysis for trying to identify what diseases may be most appropriate for which Cure ID could have the potential to collect and provide valuable information. One of the diseases that came up quite early has been mycetoma and its refractory forms. And there were many questions that we wanted to engage within the community to figure out a little bit more about what can be collected. So for example, the capacity to diagnose the etiological agents that may be present in a variety of different geographies, and we've seen the challenges in diagnostics. The extent of drug repurposing, some may be some challenges there as well. The extent of surgical interventions, and then obviously the loss to follow-up. So as a result of this, WHO actually contacted and interviewed a number of key informants for essentially an initial inquiry in both the fungal as well as that bacterial forms of mycetoma in many middle-income countries, many of who are actually present here today. And the feedback actually prompted a larger investigation of the form of the WHO online survey and was eventually extended to include not only mycetoma, but Chromoblastomycosis and Sporotrichosis, which is the reason why we're having this webinar today. So what's the survey expected to do? It's roughly around 16 questions, and it really tries to get a little bit better handle on what the diagnostic capabilities and capacities are in country at different levels of the healthcare system. What are both the pharmacological and non-pharmacological treatment practices that are occurring? What information is there, if at all, on drug repurposing? And whether there's data available and whether those medicines are actually affordable or not in those areas and indications of loss to follow-up. So this is the survey. Again, it was mentioned it's available in multiple languages, in English, French, and Spanish, to try to reach the widest possible audience. The deadline for the survey is actually on March 15th. So hopefully over the next month, individuals on this call and colleagues, so I recommend that you can forward that that survey to other colleagues that you know can be able to provide some feedback and information. The more feedback, the greater the uptake, the better information that we'll have to be able to make some recommendations. And so what are some of those recommended next steps? So this baseline information that's going to be collected through the survey will be analyzed to determine whether this platform, which is known as CureID, could potentially collect useful information on drug repurposing specifically. The survey will provide information on not only best practices and capacities of countries and regions to diagnose and treat these subcutaneous mycoses, but to also extend the global network of health professionals and researchers working in these neglected skin diseases. A couple of important reminders before I wrap up. The next webinar, and I think Marianne has put this into the chat, is going to also be hosted by ISNTD, likely in April, to share results and discuss those next steps with the community. So this is going to be a community effort. We're not only asking for this, but we want to include the community in the discussions and ways forward. Respondents, I should also remind everyone that that you make sure that you click the submit button at the end of the survey. So unless you click the submit button, it won't be actually submitted. And also anonymous submissions are an option. They are available. We obviously want to hear from everyone, and if they prefer to do this anonymously, then that's an option that's possible as well. So I'll thank you and thank the organizers for this this conversation. We'll hopefully maybe have time maybe for one question. If you want more information about CDRC and what we do, there's a website link here, as well as you can email us at cdrc@cpath.org. Marianne, back to you. Thank you.
Dr. Schito, wonderful. I think you've wrapped up this session perfectly well. Thank you for, after hearing all of those challenges, outlining a really practical solution with a lot of actionable points, and all importantly to tackle the data sharing and what is going to come out of the survey. As you reminded everyone, please look out for the second part of this webinar, which will be collating and summarizing and presenting the main findings from this very, very important survey. And I know we've gone a few minutes over, but it was such an amazing opportunity on this webinar to really hear from a lot of different country perspectives, hear about the very concrete challenges and also some of the solutions. So I feel it's 6 extra minutes really well spent. And thank you to all the attendees for staying with us. And perhaps by way of conclusion, just to wrap things up for today, before we go ahead and think about this survey and think about next steps as well, I just wanted to invite all the panelists to put their cameras back on. And I'll hand over to yourselves for the final word. So given everything that we've heard today, and based on your experience, whether it be personal or institutional or even country specific to where you're working in, what would you say is the single most important change looking forward that we would need to make a difference right now to improving the diagnosis and treatment for subcutaneous mycoses? And everyone has about less than a minute to answer this very ambitious question. So perhaps starting with you, Dr. Schito, and then we can work our way back up through the panelists.
Sure. So definitely the diagnostics is one of the, so if we don't know what we're measuring, it's going to be very difficult to be able to treat. So I think that we need a two-prong approach. What we're wanting to do is obviously understand the treatment sort of landscape much better, but you know, without diagnostics, it's going to be very challenging. And this is you know, potentially a very important and issue to address and deal with, and hopefully we can also be part of those discussions as well. Maybe having some interactions with Fine Diagnostics, for example, who have done great work in the past. David Denning mentioned IMI. They have also been very good partners for neglected tropical diseases. So those are two things that potentially we need to come together to have both the diagnostics and the treatment to work together.
Wonderful, thank you. Professor Singal.
Yeah, for me, apart from diagnostic and treatment, community awareness and physician awareness, in addition to the diagnostic. Early diagnosis is very important, and adequate treatment, counseling. So it all goes with IEC. That's very important.
Wonderful, thank you. Dr. Estrada-Chavez.
Thank you, Marianne. Yes, I agree with our colleagues. And I think as a clinician, I think the diagnosis, the education is just basic to identify and to make a proper diagnosis. In that way, education, I think, is one of basis in order to reach out and try to get our patients properly treated. But it's a multi-task challenge that it has to be from everywhere, not only as clinicians and investigation and technology. I think in all, as a union, it will accomplish better understanding of the disease and treatment. Thank you.
Thank you. Professor Denning?
I'm very keen on diagnosis, but I think there is a very specific task that I think WHO and others could coordinate, which is a randomized study in Chromoblastomycosis of different doses of itraconazole. There was some data presented at the Chroma meeting in Cuba, in Havana, where the response rate was about 30% at 200 milligrams, and it was over 70% at 400 milligrams. That's a big, big difference. And we heard from the cost issue in Madagascar. So I think we need to know the cost, because this is long-term therapy, and we need to know what dose to use. And because the drug is generic, this is not a terribly expensive thing to do in the big scheme of things.
Wonderful. If Professor Rabenja isn't able to come back on screen, then in that case, Dr. Dagne, I will hand over to you and WHO for the final word.
And thank you all the speakers. I also concur with the need to have innovative tools with regard to diagnostics and treatment, but these are not enough. We really need also preventive innovative tools that can be implemented at scale. So I think this is very important. In addition to this, availability of or development of diagnostic, preventive or intervention tools by themselves are not sufficient. We need access to these tools. Nowadays, we know there are some medicines for some fungal diseases, but they are not accessible to the majority or to those in need. So one last word is we really need attention by policymakers, decision makers, and the international community for this most neglected NTDs. So thank you all the speakers, and I invite again all participants either to administer or share and further disseminate the stuff. Thank you.
Thank you very much for those final thoughts to all our speakers. Thank you to the attendees for tuning in and for supporting this initiative. And before we go, I also wanted to say a big thank you to our colleague and friend Barbara Milani and also Heather Stone, who were very much involved in putting this event together. So it wouldn't have happened without you. Thank you, Barbara. And thank you to all who contributed today. Having Mycetoma come on the list of NTDs was an amazing step, but of course it is only a stepping stone, and we are really excited to look to the future and to the next step. So at the very latest, I hope to see everyone again in April for the follow-up to this webinar, and if not before, at one of our weekly ISNTD Connect meetings. But in the meantime, thank you everyone, take care, and all the best.
Thank you.
Thank
Thank
you
you.
all.
Good night.
Goodbye.
Thank you.